Okay, so today we are going to discuss the renal cell carcinoma. A young lady known case of CRF developed secondary hyperparathyroidism. Now she developed renal stones. Blood results are available. Sorry. So how hyperparathyroidism is caused in renal failure? So CRF, we have chronic renal failure, decreased 1-alpha hydroxylase, decreased calcitriol, decreased calcium absorption in the gut, and decreased serum calcium, and so we have secondary hyperparathyroidism. Also, you must know that for vitamin D, cholecalciferol, we have like the 125 dihydroxy cholecalciferol. This is the active form of vitamin D. So to activate the vitamin D into its active form, so we have two stages. The first stage is the 25 is added in the liver, and the 1 is added in the kidney. So kidney has if kidney is damaged, CRF, so there will be no this and there will be no active vitamin D. So there will be no calcium from the gut, and so there will be hypocalcemia. And CRF, if there is a chronic renal failure, so there is a calcium loss. So body will have hypocalcemia. So in response to this, the body will secrete parathyroid hormone, and this will cause secondary hyperparathyroidism. CRF decrease GFR, decrease phosphate excretion, secondary hyperparathyroidism in response to hyperphosphatemia, because PTH, parathyroid hormone or parathormone, is also called phosphate tracing hormone. This is mnemonic. So PTH, phosphate tracing hormone. So if there is hyperphosphatemia, so body will produce this and body will try to release the phosphate, but during this time he will also increase the calcium level by demineralization of the bone, so we will have hypercalcemia. So secondary hyperparathyroidism is defined as a derangement in calcium homeostasis which leads to compensatory increase in PTH secretion. It primarily occurs as a result of chronic kidney disease and therefore sometimes referred to as a renal hyperparathyroidism. What is the lining epithelium of urinary tract? So stratified epithelium. It's a stratified epithelium or transition epithelium. What are the types of stones? So calcium oxalate is 85%, second most radio opaque, but the second most common. Calcium phosphate, it is 10%, but most radio opaque. They are dense. Why? Because you know that bones are also made of calcium phosphate, so they are denser. So calcium phosphate stones will be like bones. They will be much denser. So most radio opaque, but calcium oxalate is the most common, but the second most radio opaque. Cystine stone 1% radio dense, and uric acid stone 5 to 10% radiolucent. So uric acid stones are radiolucent. They cannot be detected on the X-ray. Steroid stones are yes, associated with Proteus infection. So they are also called staghorn stones. They are big stones, so they need intervention. So steroid stone are 2 to 20% and associated with Proteus mirabilis infection. What are the genitourinary complications of stone? So deterioration of renal function. They can cause kidney damage, hydronephrosis, pyelonephrosis, sepsis, fistula, rupture, and carcinoma. Yes, long-term irritation in the stones, they can lead to carcinoma, but it will take a long time. It's very rare. Similarly, in gallbladder stones, the most common cause of gallbladder carcinoma is stones, cholelithiasis. So what are the different modalities of treatment in renal stones? So if a renal stone is less than 0.5 centimeter, conservative treatment. Contraindicated if patient has one kidney or signs of obstruction. So if patient has one kidney and signs of obstruction, then the conservative treatment is contraindicated, but usually 0.5 centimeter, less than 0.5 centimeter, or 5 mm, less than 5 mm, we can treat conservative. If renal stone is less than 2 centimeter, for example, less than 20 mm, so you can go for extra ECW, extra carpal shock wave lithotripsy, contraindicated in AAA, pregnancy, stone in lower pole of the kidney. For example, this is your kidney, and this is your beautiful pelvis, and we have in the renal pole here. So the extracorporeal wave lithotripsy, this is contraindicated. Okay, in AA, abdominal aortic aneurysm, and in pregnancy, PREG. So if stone is greater than 2 centimeter, for example, greater than 20 mm, PCNL is also if stone in lower pole and greater than 1 centimeter. Since we said that you cannot do extracorporeal shock wave lithotripsy for lower pole stones, so then what will you do? Then we have PCNL. Then we have the PCNL. In lower pole stone, we do PCNL. Also, if stone is greater than 20 mm or 2 centimeter, greater. Less than 2 centimeter, extracorporeal shock wave lithotripsy. Contraindicated in AAA, pregnancy, in stone in lower pole. If stone is in the lower pole and less than 1 centimeter, flexible ureteroscopy. So if stone is in the lower pole then and less than 1 centimeter, then you can go for flexible ureteroscopy. Obstructed kidney nephrostomy. If there is a acute obstruction, due to large stone, so you can go nephrostomy, drain it through percutaneous. Nephrostomy, tube or stenting, or you can put a stent, double J stent. Okay, so here we have nephrectomy if affected kidney failure or less than 10% renal function deterioration. So we do nephrectomy in A functional, or like less than 10% function, or if so in such case we do nephrectomy. Okay, so what are the risk factors for RCC? So we have tobacco, HTN, obesity, unopposed estrogen therapy, exposure to asbestos, petroleum, heavy metals, CKD, ESR, extra end-stage renal disease, acquired cystic disease, and tuberous sclerosis. So these are the risk factors of RCC. So we have tobacco, hypertension, and obesity, unopposed estrogen therapy, okay, CKD, end-stage renal disease, dialysis dependent patients, exposure to asbestos, petroleum, heavy metals, and tuberous sclerosis. These are the risk factors for RCC. How does stone cause cancer? Stone, chronic irritation, metaplasia, dysplasia, cancer. What is the most common RCC? Clear cell carcinoma. RCC has many types. There are several morphological types of RCC. So clear cell carcinoma is the most common, accounting for 70 to 80% of all carcinomas. The tumors are made up of cells with clear granular cytoplasm and non-papillary. Clear or granular cytoplasm and non-papillary. So the tumors are made up of cells that are clear or granular cytoplasm and non-papillary. What is the second most common RCC? Papillary carcinoma. Papillary carcinoma is the second most common RCC, accounting for 10 to 15% of all RCC. It shows papillary growth pattern and is seen in both familial and sporadic form. So most common cause Most common form of RCC is clear cell carcinoma, or second most common is papillary carcinoma, accounting for 10 to 15% of all RCCs. It shows papillary growth pattern and is seen in both familial and sporadic forms. What are the macroscopic findings of clear cell and papillary carcinoma? So it arises from proximal convoluted tubule, solitary and unitary, bright yellow, gray, white spherical masses. Margin are sharply defined and contains within the renal capsule. Prominent areas of cystic softening. Prominent areas of cystic softening or areas of hemorrhages and necrosis. Areas of hemorrhage and necrosis. So papillary carcinoma arises from distal convoluted tubule. Oh, so this is a big difference. This arises from proximal convoluted tubule. This arises from distal convoluted tubules. We have bilateral and multiple. These are solitary and unitary. Less vibrantly orange yellow. Less vibrantly orange yellow because of their lower lipid content. And papilla formation with fibrovascular cores. Papilla like this. Papilla formation with fibrovascular core. Areas of necrosis, hemorrhage and cystic degeneration. So they have areas of necrosis, cystic degeneration and hemorrhage and cystic degeneration. Okay. So what are the microscopic findings of clear cell carcinoma and papillary carcinoma? So rounded or polygonal shaped cells and abundant clear or granular cytoplasm which contains lipid and glycogen. Lipid and glycogen. And here we have the cuboidal or low columnar cells arranged in papillary formation. Interstitial foam cells, samoma bodies may be present. Stroma is usually scanty. Samoma bodies may be present. Interstitial foam cells, and we have cuboidal or low columnar cells. Cuboidal or low columnar cells arranged in papillary formation, and interstitial foam cells, samoma bodies may be present, and stroma is usually scanty. You can also see the same here. Cuboidal or low columnar cells and samoma bodies. Samoma bodies are deposition of calcium. So interstitial foam cells as well, and stroma is usually scanty. Okay, so what is R1? So remember that the microscopic residual tumor. R1 is microscopic residual tumor. So the tumor status following treatment is described by the residual tumor R classification. So we have R0, no residual tumor. R1 is microscopic residual tumor and R2 is macroscopic residual tumor. R2 means that if you see with naked eyes, so you will get like the tumor, remaining tumor, and R0 is no residual tumor, you can't see, and R1 is microscopic, you can see through microscope. Which staging system is used for RCCs? So we have the Robinson staging system for RCC. So what is it? You can see it's a very beautiful picture in vena cava, aorta and lymph nodes, and this is the adrenal gland. So this is stage 1, inside confined to the kidney, and then we have the stage 2. Okay, it's based on the size. So in stage 1 we have less than 7 centimeter. Stage 1 is less than 7 centimeter in largest dimension, limited to the kidney. So less than 7 centimeter, and then we have the greater than 7 centimeter largest, limited to the kidney. So this is greater than 7 centimeter. Okay, and then we have the tumor in the major veins or adrenal gland with intact aorta, fascia, original lymph nodes involved. So stage 3 is here. Stage 3, yellow color, so it can be here and it can involve the major veins like the renal vein. So tumor in the major veins or adrenal gland then take Geroda fascia, regional lymph nodes involved. 4 is beyond Geroda fascia. When Geroda fascia is breached, this is Geroda fascia. So when it is breached, so we call it a stage 5. There is another classification. I will put its picture in the channel, that we have the vena cava extension and so on.